Hello and welcome to HealthWatch. I'm Dr. Vince Yelmy. On behalf of the physicians and staff at Ephrata Community Hospital, I'd like to welcome you to this segment. Today we're going to be talking about weight loss and bariatric surgery part 2, and we'll be right back after this message. And welcome back to HealthWatch. Today we're going to be talking about weight loss and bariatric surgery, and I title it part 2 because we've done a segment of this a week ago and presented that. And it was kind of an interesting story of a patient that in fact went through the program, and I hope people have watched that and have access to that because it was that human interest part of it. But today we're really talking about kind of the nuts and bolts of it, how it actually works. And as our guest, we have Penny Musser, who works at the center, and again, Dr. Matt Davison, who performs the surgery. So welcome to the show.
Thank you.
Kind of starting again with Matt, kind of statistically, I know you personally have done several thousand of these surgeries, I mean, over time, and so you have a vast amount of experiences. And Ephrata is a relatively new program, and we've done about 40 or 50 of these, as I understand it.
Correct. We've been actually only performing surgeries here for a little over a year at this point, and so it takes quite a while to get ramped up. When we choose our patients, they get a lot of counseling. I think our average time from meeting a patient to surgery is around 9 months. So it does take several years until you're routinely doing surgeries every single week. But we have our first year under our belt, and our patients have been very successful. We're very happy with the outcomes.
Yeah, I know at the hospital, when we started to get into this, and our first discussion with your group was really one of preparing the nurses, the surgery seats, so everybody understood from day one, and that's been quite successful. Our complications and follow-ups have been really quite excellent. I mean, we had very few.
Yeah, it really does. I mean, it's a whole team approach from the nurses to the support staff. As we'll talk to Penny later in this segment, we have several people that work in our office that have had the procedure done, and it really is a complete team approach, lifestyle change, and that's how you get to be a center of excellence, which is our goal. And so far so good, I think, here at Ephrata.
Yeah, great. Well, Penny, I want to speak to you particularly because you used to work for the hospital in other areas, but chose to go to the weight loss center, but also have had the surgery itself.
I did.
So just give me a quick profile of that. And you've given us permission. I think we have some pictures here of before and after pictures. And I'd love to show those. You look excellent.
Yes,
and
thank you.
And how long has it been since you had the surgery itself?
I had my surgery September 7th of last year, the day of the flood.
Oh, that's great.
Yes, I have lost 126 pounds since then. What made me decide to do this is I was on 7 different medications, including diabetic medicine, high blood pressure, high cholesterol. I had surgery Wednesday, came out of the hospital Friday with absolutely no medicine. So it was a big improvement in my life right away, even before I lost any weight.
Yeah, that's a fascinating phenomenon, I think, and Matt, maybe you want to comment on that. The whole idea of diabetics, because I know you were on metformin, I think you had said,
yes.
and diabetics and difficult controls and all those kind of things with high hemoglobin A1C. I can't get it down, and we've seen dramatic results in that. Just speak to that. Are you seeing this in your practice?
It's routine, and it's an amazing phenomenon. There's a lot of studies going on across the country. We don't know exactly why these occur. A lot of it, we were speaking earlier about hormonal fluctuations. Sure. Everyone knows about insulin spikes, and we want to avoid those for the diabetics, but it goes beyond that. Hormones that will take into account cholesterol and hypertension and all those things. Patients really, from the first day, come out medically better than when they went in, and they haven't lost any weight yet. And we don't really know why that is. I mean, maybe a steady calorie, they come right out on a special diet where they have small little meals a day, and just that alone might be part of it. The effects are really dramatic, and they start really immediately.
Yeah, because we see other people have surgery that are diabetic, and we're always chasing after their sugars, and it becomes more problematic because they tend to spike. But we didn't in the bypass surgery. It's like it's dramatic. I mean, it's really kind of.
They're on regular caloric intake at certain intervals, or rather than, fasting can be just as bad as overeating for regulating yourself medically. And so they're given a special diet, and they eat at the exact time, the exact amount, the calories are adjusted. And so, I'm sure that's at least part of it.
Yeah. Getting back to you, Penny. I mean, I know after the surgery, you now work at the center.
I do work at the center.
And I know our previous guest, Nick Saragusa, who was here, was nice enough to share his story, was relating what an important part of that was to the whole process. This is not just surgery; it's a lifestyle changing thing. So, tell me about the patients that they walk in the first day, and you are the point person.
I am. The first thing they need to do is come to one of our info sessions, which is free, and we have one the first Thursday of every month over at the hospital. They can call and sign up for that. I will check their insurance before that to make sure, because some of the insurance is still bulk at it, but I will make sure that the insurance does cover it before they come. After the info session, if they're still interested after seeing Dr. Davidson speak there, then they will come in and talk to me, and I'll leave them know what their insurance covers and where they're at with the finances, and also what the requirements are, because all the insurances are different. We will set them up to see the doctor and also the nutritionist. They will need to have, all the insurances do require a psychological evaluation. That is on them to make that schedule. But after they go through, it's usually an 8 to 9 month process from the time they start until they actually can have surgery done.
Yeah, Nick was remarking about the support group that he had, I guess before and after, and the motivational. Tell me about the support group a little bit if you can.
We have 2 support groups a month, actually. We have one the first Tuesday morning of every month, which is held at the hospital. We have one the third Thursday evening of every month. And it is a big help. I know even for myself, having the surgery, it's good to get around other people that are in the same situation you are, that understand, because it's something that a lot of people don't understand. At this point in time, we have a lot of pre-surgeries also that we're able to help the people that are coming into the program to understand more also before their surgery.
Yeah, Matt, you were commenting on that many of the people that work actually at the Ephrata Wellness Center actually, in fact, have been a patient and have gone through it, which has got to be a tremendous help, I would think.
Definitely. The patients appreciate that, because we don't just sit and tell them what to expect. We understand what they're going through. And everybody goes through the same thing, but at different times a lot of times. So it makes them feel better, more comfortable about it, because it's definitely a big change. It's a change of life.
When you see a patient, are they referred to the center, or how do they get to you? Are these self-referred? What's your experience have been with many of these patients?
A lot of the family doctors will refer them to us, but a lot of times they see our ads and they get to the point, I believe, where they're tired of having diabetes and they realize they need to do something about it, and they will call us on their own. Yeah.
So we've talked on a previous show about some of the requirements, Matt, and we talked about body mass index and some of the requirements that any insurance companies supporting this as well. Tell me just quickly about that. I mean, they're not everybody that shows up obviously is not a candidate for surgery. They may not fit the body mass index requirements or from other issues. The selection process. I mean, we encourage people to lose weight, not all of them needing surgery.
Right. And I think that's important. Number one is you don't need to have a referral from a physician. They're busy. They can be hard to get into. There's different, we love referrals, but you don't have to. If you're a patient out there, you can take it upon yourself. I wouldn't worry about the requirements, because we will take everybody and help them if they need to lose weight, whether they're someone who would be able or even want to have surgery or not want to have surgery, or if their insurance covers it or if they don't cover it. If their insurance doesn't cover it, we have payment plans. So I guess what I would say is, if you're someone who wants to lose weight, regardless of your size, your medical history, no matter what, all you have to do really is call us and come and speak to us on an individual basis. There won't be any surprises financially. Penny is our financial advocate, and she'll go through everything with them so they can know what to expect, what do they cover, how much are they responsible for, etc. Most of the time now the insurance covers the far majority of it. So it's a case-by-case basis on who would qualify for the surgery. Just because you qualify doesn't mean that's what you should have or even want to have. And so I would say just call us and come and speak to us, if you're interested.
Serious about it. We're going to take a break and come back and talk about, again, that whole process that you go through up to and including the surgery. So we're right back after this message. and welcome back to HealthWatch. We've been talking about bariatric surgery and weight loss, and I probably should put weight loss first because not everybody that comes to our weight loss program requires bariatric surgery. Some of it has to do with, and you mentioned this on the previous show, this body mass index issue. A 40 body mass index, we use that terminology a lot, but people can't relate that. I mean, I know if you go to a doctor's office now, by definition, they must do height and weight and report your body mass index, whether it's your family doctor, I mean, whether you're a specialist or whatever, you're required to put that in. So we're becoming more aware of what that is. But a 40 body mass index is a pretty large person.
Well, it's considered, the BMI is now considered the 5th vital sign, so that's how important it is. And people can get online and find BMI calculators and put in their height and weight, and it'll tell them what it is. So you might be surprised, people that are, and some people with a body mass index of 35 and over, it's really hard to tell just by looking at someone. There are people who qualify for the surgery, their body mass is more dense. And so there's patients that we have that do not look that overweight that medically qualify and need the procedure. So I wouldn't base it just on how someone, if they look very obese or not. You really have to put in their height and weight and see if there's someone who would qualify or not.
Qualify for that. And you talked about, I think at 35, and we see so many of these comorbid conditions, unfortunately, for example, yourself, Penny, yes. That in fact would qualify you even at 35. 40 was a kind of an absolute, but 35, I know, if you're diabetic, you're hypertensive, you have heart failure, sleep apnea, would in fact be qualifying you. So you look at all those factors when they first come in, I assume.
Yes, we do. We look at all those. Of course, the first is a BMI. Then after that, if it's 40 to 35, we look at comorbidities. We also look and see if the patients are going to be compliant, because we do have 6 months of nutrition that they need to go through, whether their insurance wants them to or not. When they come in for those, they need to have food logs and show that at least they're trying and that they're really, this is what they want to do because it's such a change.
Yeah, and I think we were talking about that at the break, and we might emphasize that commitment we're looking for from the patient. It's not just our commitment, right. It's their commitment. And you were speaking to that, Matt, that you've actually turned people down who in fact did not show that, because you can predict they're not going to do well, right. Post.
Yeah, it's not, people that are looking for a quick fix in general are not going to do well. This is a lifestyle change, and if the viewers were watching Nick when he was on, you can see how he speaks about the entire lifestyle change. He doesn't talk about the surgery, he talks about how he changed his life. And so that's what we're looking for. If patients aren't even willing to come for 6 months of dietary counseling and come to support groups and do the things that we ask, the surgery is not going to be the answer for them. That's a tool that helps them do what they need to do. But really, the patient compliance is the key to the outcome. And we try to weed out patients that we think aren't going to do well, because it is a big surgery and it's a life-changing surgery. And so I think that's very important. And I think Penny and the rest of our office staff do pretty well at helping to weed those patients out.
I think you were talking about, and done this on the previous show, we talked about, let's just use a 1 out of 10, if we want to use that statistics, will gain back the weight even if it had bypass surgery, which is really distressing, but they always are the ones you hear about. Right. They're out there saying, oh, I gain weight, or the perception is that this thing doesn't work. Look, she's back to what, or he was back to what they were before. But the reality is 9 out of 10 actually do maintain the weight, and like you say, Penny, you're healthier than what you were by a long shot, and that's our continuing program. It occurred to me also that these are not singular issues. I mean, these people come with family. What about the spouses of these individuals or their loved ones, whatever that would be? But how do you incorporate them into this? Because it seems like that's a kind of a team effort to me. I mean, if the wife is cooking or the husband's cooking, that's a change in their whole lifestyle. And I've heard people talk to this. Speak to that if you would.
We encourage that from the time that they call for the information center, that they come along, because it's definitely something that they're going to need that support, and they understand that, and also as well as a patient. We encourage them to come along to every doctor, nutrition visit, whatever they have to get involved in, because it's not just changing the patient, it's changing whoever they are living with, their families that aren't even with them. Because I say it's like going back to being a baby again and starting all over, because you got to change your lifestyle. And a lot of people don't understand that afterwards.
Yeah. Yeah, I have to admit, I'm talk about lifestyle. If you watch TV and you watch a Mike and Molly show, which have two rather
Yes.
large individuals, but promoting that is just another issue. It bothers me. I laugh at it, but on the one hand, I'm thinking, gee, that's not the norm, and you don't want to promote that. So there are lifestyle issues, and sometimes it is. If you have a very thin wife or husband with a very large spouse, it does create all kinds of issues that I can think would become problematic. The insurance issues you talked about, again, you talked about going over this, and we do require the 6 months. Are there? I know initially when this surgery came out, and that's Nick or Matt, how long have we been out there with the surgery? The surgery itself has been out for some time.
Well, the surgery, I mean, the medical community has been doing the surgery since the 1960s. We've honed it now to a much more, lower complication and so forth. My particular group has been doing this for, about 12, 13, 14 years, and we've been doing it at Ephrata. Really, this is just our first year that we've been actually doing the surgeries here, but the surgery itself's been around for quite a while.
Yeah, I think that having been involved as a physician over the years, it was kind of some skepticism because guys were doing it, not understanding all these other aspects of it, and so it kind of a big serious, boy, this really works. To gee, there's a lot of complications, and I'm not sure I'd want to do it based on the risk issue. But we've gotten much better at it.
Yeah, you really want to have someone that's devoted to doing that for their career because there are a lot of nuances to it. But in the right hands. The complication rate, for instance, is much lower than like a hip replacement or an open heart surgery, things that we consider standard surgeries today. The complication rate of these procedures are much lower and the mortality is lower. So it's really just a matter of having honest conversation with people about it.
Yeah, I think people, they're looking at various programs because I know they're throughout our community, but you really should be aware of the experience, the complication rates, and they're available to you, right? Those things are posted now. You can inquire. Certainly, of Ephrata, we'd be proud of our statistics and your statistics, but various programs have not had the same experience, and I think should be avoided. So the insurance company, Pam, we alluded to that. Patients can, if they have insurance, can go to their insurance company, and most of them now are approving these surgeries. It wasn't always like that.
Yes, most of them are approving it. They all have different criteria that the patients need to do. But with our program, we do have certain requirements, even if like I said, one of them is 6 months of nutrition. We require that because the patient needs to be educated on that. But most insurances, especially if they have a BMI of 40, it's definitely, now it depends on the plan for the insurance also, but it's been going through a lot easier than it has been, I know, in the past few years.
Yeah, I think as a payer, you'd look at this and say, how much am I going to pay a lifetime of this patient versus for this procedure, and it just makes financial sense.
That's right.
Yes.
Yeah, I can understand that.
Yes.
So absolutely, when we talk about going in for the surgery, all those things are done ahead of time where patients are ready for surgery and they come to Ephrata Hospital to have that. Most of that stuff is worked out ahead of time. They go through a preoperative evaluations and all those kinds of evaluations necessarily they need to have. They see our anesthesia staff. And they say it's basically a 2 or 3 day stay now.
Yes. The bypass, you go in usually on a Wednesday, come home Friday, and the lap band, you go in and you can come home the same evening. It depends on it depends on if your complications.
Types of surgery. Yeah,
yes.
we've had very few of this. We're going to take a break, and I want to come back and really talk a little bit more about the surgical procedure itself. We'll be right back after this message. And welcome back to HealthWatch. We've been talking about the bariatric surgery itself, and I think it would probably behoove us to at least talk about some of the issues now that have progressed even in the last years, I think, since you were on this show, talking about the bariatric surgery itself. What is the experience in the community? I know that we talked about the bypass surgery, and not to get too technical about it, but it is a bypass of the stomach and the small intestines. But the banding procedure, what's your experience have been? I mean, people say, gee, I'll have banding. That sounds like a neat thing to have.
It's one of the problems as a surgeon we have to weed through because of the internet. Everyone has done some research on them, and I encourage people to do their research. Sure. But what I try and discourage them from doing is coming in with a bias, because even though they've done research, listen to their surgeon because he's lived it. If you pick the right surgeon, he should have done thousands of them, and he has an experience to go on. And there's 3 main surgeries that we're doing now. We'd spoken earlier about a gastric bypass, which is restricting the amount of food as well as bypassing a portion of the bowel so they don't absorb as many calories. The sleeve and the band are purely restrictive surgeries where it's basically just reducing the amount of food that the patient eats until they feel full. All three surgeries are dramatically different. We could spend an hour on each one. And there's obviously pros and cons to each one, or else there would only be one procedure if there was one that was perfect. So none of them are perfect. And depending on the patient's dietary history, how much weight they need to lose, even their body type and their sex of the patient, if they're male or female, their age, there are so many things that go into choosing a procedure that I encourage them to educate themselves on them, but try not to come in with a bias. So the ultimate goal for us and the patients is to have success.
Okay.
Right, and so we want to help educate them on why one might be better than the other.
Yeah, you talked about, the various surgical surgeries. I know the sleeve has been entertained as a newer procedure. I know we just began to hear this in the literature. Your bias, is school still out yet?
Yeah, it's a little early to have long-term data. The short-term data is excellent on it. It is still a rather invasive procedure, different nuances to the bypass. There are some things about it that are less invasive, meaning there's no connections in there that we have to do, but it can be considered more invasive because we're actually removing a portion of the stomach, which is permanent. So that's something that you have to take into consideration. The short-term data, excellent weight loss. The question we have is how will it do long-term? Will the patients maintain that as well as they do with, say, the bypass? Again, it's a restrictive procedure. It's non-adjustable like the band. The band is another purely restrictive, but it's adjustable. If patients have trouble down the road, we can tighten or loosen it as we need to. So again, short-term data on the sleeve looks excellent. We've been doing it a number of years, but no real long-term data on it yet.
Yeah. And I guess the other thing is that people have to understand that you do these laparoscopically.
Correct, all three are done laparoscopically.
Yeah, I think there was a time, there was this question of laparoscopic versus open, and you had the guys that,
Right.
But I think it's kind of state of the art now. If you're not doing it laparoscopically, you probably shouldn't be doing the surgery.
That's right, and the complication rates are lower, the pain's lower, recovery's less, and less hernias, less infection, right down the line. So yeah, you really should be, I think, seeking out someone who's experienced in doing them all three laparoscopically.
What is your major concern in the patients that have the surgery, immediate complications?
Really no different than your standard hernias and gallbladders and so forth. It is a high-risk patient population because they're, by definition, obese. So, things like blood clots, infections, it would be rare to have bleeding, but certainly any surgery you can have bleeding. If they have a heart condition beforehand, the stress of surgery. So we try to limit all these things and get them a full medical evaluation before the procedure. But to be honest with you, short-term complications are really no different than your standard hernia gallbladder type of surgeries.
Yeah, an anastomotic leak, you are sewing things to other things. That was always the major problem when we were just doing these cavalierly, but now you really got this down to a science.
It really is, the way that it's reinforced, and then testing during the surgery, testing before they go home. While leak is still a known complication in the literature, again, research your surgeon's leak rate. Make sure that they have a very low leak. It should be, we'll see a leak once every several years, and we do hundreds and hundreds per year. So things like that are things that you should ask your physician, sure, what is your leak rate, and compare it to the standard. That's right. Perfectly acceptable to do.
The other things that we know in the past, the kind of dumping, the diarrheal syndromes, all those kinds of complications, I think you pretty much have worked through now.
It's really become, when bariatric medicine is a full-blown field in of itself, and a lot of research done, and the length that we bypass, and the size of the pouch, and all the little nuances to it have really been, I think, honed down to where we don't see many of those things, and we know how to counsel patients that are having the issues like dumping syndrome and so forth. So the satisfaction rate with these procedures in general is very, very high at this point.
Great. Penny, getting back to your follow-up now, these people have had their surgery and now they're coming back to the center. What are you looking for now? What are their requirements, and what should they be doing with the center?
They come back 2 weeks after surgery to see the doctor, and they come back 3, 6, 9, and 12 months, and then every year. We do lab work each time they come back to make sure that their vitamin levels, because they will be on vitamins for the rest of their life, and all that stuff is taken care of. And that is part of the reason. Also, support group, we do encourage them to be at support group each month. They definitely need that. We're there if they have any problems or concerns. They can call us and we will walk them through whatever needs to be done or get a hold of the doctor to see what we can do. But they see the doctor quite often, and it's one of those things that we definitely want them to take care of.
Yeah, I think that the emphasis has been, and as we've discussed, it's a lifetime issue.
Yes.
We're not looking for quick fixes here.
Right.
We're looking for long-term commitment. So, even incorporating the family doctor, as many of these people have, trying to integrate, make sure that we're truly integrated, that they're part of the process. Because as you said, the dramatic drop-off in your medications, I think is a real lesson. You'd have to know that ahead of time. How do we make sure to keep the physician informed, their family doctors
Right.
informed of this? How do you do that?
Well, you also go back to your family doctor after surgery also, because they are the ones also to help to keep track of your medication. I think they're amazed also at what happens after surgery, and it's great because then they can refer more people to us also, patients that, because I know everybody's very questionable about the surgery at this point. But it's great, to keep them all together up with it.
I think one thing is that the rate at which they come off their medications is so high that generally by the time we send them back to their family physician, we have those things generally squared away. I think that helps a lot too.
Yeah.
Usually by the time they return to their doc, they're on their standard meds that they're going to need.
Okay, I got to wrap. But it's been wonderful talking to you guys again. I think we've really covered the topic well, and I'm hoping to encourage people to look for the Weight Loss Center and potentially bariatric surgery in the future. Thank you for coming, and thank you for watching HealthWatch.